Hello everyone and welcome back to our DNB Ophthalmology Highlight series. Today we are diving deep into the must-know topic for your exam, that is Ectopia Lentis. This is the one condition that shows up repeatedly in your clinical exam, and for that reason it tests your understanding of lens anatomy, systemic association and surgical decision all at once. So by the end of this video, you will able to confidently tackle any question on lens, subluxation, dislocation, identify the classic systemic syndromes, understand the mechanism behind the pupillary block, glaucoma, and know exactly when and how to intervene surgically. So let's get started. Alright, this is our first case. A 20-year-old male present with gradual diminution of vision, both eye since last 2 years. Now, along with this, he reports episodic eye pain with headache and halos around the light for 5 days. Now, see, eye pain, headache, halos. This combination immediately suggests raised intraocular pressure, possibly the acute angle closure. On general examination, if you notice, the patient build is short stature, build and short fingers called brachydactyly. This phenotype is important. It points toward systemic syndrome, possibly WMS or Weil-Marchesani syndrome. Now let's see the clinical findings. His IOP is 30/28, vision is 6/12 in both the eye with high power, that is -10 and -11 diopter. Notice the high myopia in the both eyes. The patient is young with short stature, elevated IOP. This is the classical diagnostic clue. Look at the slit lamp images. You can see the lens look thick, small and spherical rather than its normal flat dish shape. Now when we look at the slit lamp images, we see something very characteristic. The anterior chamber depth is shallow. The iris is anteriorly bowed. The lens appear anteriorly positioned and thick. The pupil appears to be mid-dilated and fixed. The mid-dilated pupil is a classic sign of angle closure crisis. This is the question which have been asked. Give the ocular finding in figure A and B. What is the provisional diagnosis, mechanism of glaucoma, myopia? Mention the preferred line of management. What is the method of slit lamp examination used in the following figure? Now see this video. This is the slit lamp section. If you see, it illuminates the cornea tangentially at the limbus. It is used to detect the subtle corneal changes like corneal scars, cornea opacities. This imaging technique is called scleral scatter, which we will discuss later. Now let's look at the second question. What do you see in the image? The lens is not in its correct position. It is subluxated inferior nasally. The question are: identify the ocular condition, mention the two common reason, what is the refractive patient of this patient, write one medical and surgical treatment option. We will answer this question soon, but first understand the underlying concept. This is the third case in which 16-year-old boy complained of blurry of vision. Look at this anterior segment photo. Can you see the edge of the lens visible through the dilated pupil? The lens is subluxated and it is displayed superiotemporally, but it is still supported. The question are: what is this condition? Name two indications for surgery. Give two surgical option. Now let's build our conceptual understanding with some diagrams. See, this is the diagram which show the basic concept of Ectopia lentis. Normally, the lens sit in the patellar fossa, held in place by zonules attached with the ciliary body. In Ectopia lentis, the lens is displaced from its normal position because either the zonule are absent, weak, stretched or broken. This is the very important distinction for exams. Subluxation means partial displacement from the patellar fossa. The lens edge is still within the pupillary area. Some zonules are intact in this condition, whereas dislocation means complete displacement. The lens lie completely outside the pupillary area. It can be either in the anterior chamber or in the vitreous cavity. Here the zonules are completely disrupted. Now let's talk about the systemic causes of ectopia lentis, which are high yield for the exams. There are three main hereditary syndromes which are shown here. First is Marfan. Lens is subluxated superior temporally up and out. Here zonules are intact but they are stretched. The lens appear in normal size and shape. Second condition is homocystinuria. Here the lens subluxate inferior nasally, that is down and in. Here zonules are brittle and fragmented. Lens can appear normal in this condition. Third is WMS, Weil-Marchesani syndrome. Here the lens subluxate inferiorly. Here zonules are elongated and weak. So the lens shape is small and spherical, also known as microspherophakia. Now let us see the complete picture for all these three syndrome. In Marfan, ocular will be open angle glaucoma with angle anomaly. Pathogenesis is fibrillin 1 defect, gene name is FPP1. It is autosomal dominant. Systemic feature will be tall, thin build, arachnodactyly with high arch palate. And with systemic association associated with heart is aortic root aneurysm and aortic dissection. Second is our homocystinuria. It is rarely cause pupillary block. Pathogenesis lies in cystathione beta synthase deficiency in B6 vitamin synthesis. It is autosomal recessive. Systemic feature will be tall, thin, developmental delay associated with thromboembolism and decreased cardiac anomaly, which is rare. Third is Weil-Marchesani syndrome. Ocular finding will be pupillary block, acute angle closure. Here the cycloplegics are contraindicated. Example pilocarpine. The pathogenesis lies in the extracellular matrix abnormality. Genes are autosomal dominant or recessive. The systemic feature will be short stature, brachydactyly, stiff joints and cardiac anomaly. Here WMS में the gene for autosomal dominant is same with Marfan, but the genetic mutation is different in each of the gene. Now this is the critical exam point that often catches students. In a patient with lens subluxation or microspherophakia, pilocarpine can actually make it worse. Here it is why. Pilocarpine causes pupil constriction. When the pupil constrict, it causes lens diaphragm to move forward and inward, blocking the pupil completely. This leads to complete pupillary block, causing the ciliary muscle to contract, which pulls the lens backward. So ultimately, it will lead to zonular tear. The lens can completely dislocate into the vitreous. Atropine, on the other hand, cycloplegic. It paralyzes the ciliary muscle, moves the lens iris diaphragm backward. It dilates the pupil and bypasses the block. So remember, atropine is helpful, pilocarpine is harmful in lens subluxation associated with pupillary block. So let's understand mechanism of primary angle closure glaucoma in this context. The upper diagram, if you see, it is dilated iris blocking the trabecular meshwork. There is increased trabecular meshwork contact. This will lead to rise in intraocular pressure. If you see the lower diagram, it shows what happened with the use of pilocarpine. The pupil will constrict, the iris is pulled away from the angle, but the lens move forward. worsening the pupillary block. That is why pilocarpine is contraindicated in microspherophakia. But in PACG, as the iris contract, there is decrease in the trabecular meshwork contact, so the aqueous got space to drain from the trabecular meshwork. Now, sometime they ask the question is what is the refractive status in Ectopia Lentis? Now see, when the zonules tension are getting lost, the lens will become more spherical. The spherical lens have increased curvature, which means there is increase in lenticular myopia. On the other hand, if the lens is outside the visual axis or in the aphakic position, the patient will suffer from hypermetropia. The diagram shows the same. Sometimes that tilt on the lens can cause lenticular astigmatism. If the split is equal, it will lead to monocular diplopia. Now let's discuss the surgical treatment option. For mild subluxation less than 3 clock hour, CTR capsular tension ring can be inserted. For moderate subluxation 3 to 6 clock hour, capsular tension segment, which is sutured capsular segment, and we can also use modify Sioni ring. For severe subluxation with the absence of capsular support, SFIL or iris claw lens can be used. Now we are going back to our first case. Let me walk you through the systemic approach for answering this question. First is, what is the method of the slit lamp which is used? Now see this. When we are moving the slit lamp tangentially at the limbus, the other side of the limbus get illuminated along with any opacities in the cornea medium can easily be seen. So this is known as sclerotic scatter. So how it develop and why it develop? Here the illumination system is on one side, microscope on the other side. The slit on the limbus creates a optical section through which the light beams goes and causes total internal reflection within the cornea. If you see this yellow line, it represents that. Any lesion on the cornea we can see. Now here actual how the we can decouple this to get the sclerotic settle. This is the knob we need to loosen up so that the optical system will get detached. Let's summarize this question. The 20-year-old male, decreased vision with pain, headache, nausea, vomiting. Patient is high myopic with high IOP. Short stature suggests Weil-Marchesani syndrome. So answer for our first question is ocular finding. There will be shallow anterior chamber. There is anterior bowing of the iris. Lens appeared to be placed anteriorly and thick. The pupil is mid dilated. This is the classical sign for acute angle closure crisis. Second question is what is the method of slit lamp examination used? The technique is known as sclerotic scatter. It used to assess the corneal changes and opacity scars, assess the position of the lens and anterior chamber depth. What is the provisional diagnosis? It is primary angle closure glaucoma with either it could be Wheel-Marchand syndrome or nanophthalmos. What is the mechanism of glaucoma for this patient? The thick anterior displaced lens creates the pupillary block. Echoes cannot flow through the from posterior to anterior chamber. The pressure behind the iris will keep on building and that will cause bowing of the iris forward. This will block the trabecular meshwork and cause the angle closure glaucoma. The mechanism for myopia in this case is the lens will have very high curvature that will lead to lenticular myopia. What is the preferred line of management? Immediate management will be to control the IOP with topical beta blocker, alpha agonist and systemic acetazolamide. The definitive management will be to do laser PI to relieve the pupillary block. If this is unsuccessful, we can go with lens extraction with surgical iridectomy. And following this, we need to confirm with axial length measurement, ASOCT and UBM to confirm the mechanism. Now let's move to second case. This is the case of Ectopia lentis with lens dislocation. Two common reasons for this condition. First is Marfan syndrome. Second is homocysteine. Marfan is a connective tissue disorder with zonal weakness. Homocysteine is a metabolic disorder affecting the connective tissue. Remember the direction in Marfan, it will move in up and out, superior temporal. In homocysteine, it will move down and in, that is inferior nasal. Refractive status, it all depends upon the position of the lens. If it partial lies in visual axis, high myopia along with lenticular astigmatism can be there. If it is completely out of visual axis, it looks like functional aphakia causing high hypermetropia. Next is medical and surgical management. Medical, we can give cycloplegic, IOP lowering agent, and finally surgical if that are not successful. Let's finally address the third question. What is this condition? It is known as ectopia lentis, likely non-traumatic in origin, mostly Marfan, homocysteine, Wheel-Marchand. What is the indication for surgery? If the visual impairment is there significant and it is not corrected with glasses, then we can do. And there is secondary lens induced complication like lens induced glaucoma, uveitis, lens touching the cornea endothelium. What are the surgical options? First, lens extraction via limbal or pars plana route. Second option is IOL implantation, either via SFIL, iris claw or anterior chamber IOL. It is less, anterior chamber IOL are less preferred in children. Now let me give you some high yield examples. Pearl number 1 is always mention systemic association when answering ectopia lentis question. Marfan, the lens will be up and out. The patient will be tall, arachnodactyly, aortic root dissection. Homocysteine, the lens will be down and in. Intellectual disability, thromboembolism, or sometimes osteoporosis. Wheel-Marchand in lens will be down. Patient is tall stature, brachydactyly, microspherophakia. In any case of acute angle closure in young patient with myopia, always rule out microspherophakia or lens subluxation. Always do UBM anterior segment OCT before planning surgery in ectopia lentis. We need to know the degree of subluxation, anterior chamber depth, zonular status along with thickness of the lens. Let's quickly recap whatever we have covered today. Ectopia lentis, the displacement of the lens will be there from its normal patellar fossa position, either due to zonular weakness or disruption. It can be subluxation or dislocation. In subluxation, there will be partial displacement. Some zonules will be remain intact. In dislocation, there will be complete displacement. All zonules will be disrupted. Major cause of Marfan, homocysteine, Bilmachani, and trauma. Complication include pupillary block glaucoma, lens-induced uveitis, cornea endothelium damage, and it can also lead to retinal detachment. Management includes cycloplegic, IOP lowering agent, surgical VB, lens extraction with and without IOL implantation. We can do SFIOL, iris claw, and anterior chamber ACIOL. And that is up for today's session for Ectopia Lentis. I hope this have given you clarity to tackle exam question, whether it's Viva MCQ. Remember, ophthalmology is all about pattern recognition and systemic thinking. The more you visualize these cases, the understand the mechanism, the better you perform. Thank you.